engaging in the behavior itself. And so the kids with fast impulse control or with poor impulse control tend to see something and go, that's cool, and before they think about it, they've already done it. So often when they do something and then they realize, oh no, that was really stupid, I'm going to be in big trouble, that's different from a kid who says, you know, I'm going to do that. I know I'm not supposed to, but I think I can get away with it. Whole different type of individual.
What if you have a situation where that child has both?
That's your ODD or budding on conduct disorder kid who also has ADHD at the same time.
And how have you dealt with that in your profession?
Hopefully set up, depending on the age of the child, some kind of contract that helps get this behavior under control, as well as the therapist coaching that individual to help them realize the need for that and to understand how, if they had ADHD, how they might have kind of drifted into this mode, but try to help them see that in the way life is going to treat them isn't going to be very pretty if they don't change it. That's easier said than done, but when that does happen, you can get that behavior to turn around. So it's really important that for early intervention, basically, hopefully, if the child has ADHD or learning disabilities, those things are identified prior to the age of 8, because then their prognosis is a lot better. The later you wait to diagnose it, the more the possibility that they could move into the ODD or conduct disorder.
I'm sure you've had children who refuse to take their medications.
Yep.
What do you do?
We try to talk them into it. We try to have a reward system, quote, bribe them, which of course it isn't bribery because we're rewarding them for doing something appropriate, not something that's illegal or inappropriate. But try to come up with a way to get them to take it, where they earn additional privileges or something, because usually if you can get a child to take it for a short period of time, they begin to go, oh wow, all of a sudden school's easier for me, or one thing or another. They will notice, and then most kids on the meds, not all, but most of them recognize the benefit of it, and particularly now, what's great is that the newer drugs have really good long-acting mechanisms, so it's very rare that a child will have to take the med at school. They can usually take it in the morning, and it's going to carry them through the school day, because that was one of the big objections, is the kid who has to go to the office at noontime or in the afternoon to get their afternoon dose.
You got your PhD from the University of Southern California.
Correct.
In psychology?
Right.
Do psychiatrists use the total focus program, the holistic approach that you're putting forth? Does psychiatry receive it in the totality and contribution that it is, and is it really being adopted properly?
It's moving in that direction. What I do at UCI is, one of the things I do is provide some, lectures, didactics for the child psychiatry fellows. So these are psychiatry residents who are in their 4th and 5th year and are going to specialize in kids. And they are very open to this whole approach, and we recommend total focus program to parents in our clinic at UCI, and I'm in the early stages of getting a research protocol together and approved to do some actual clinical research on how it benefits kids. But the new guidelines for treating ADHD now state that with kids with mild to moderate symptoms, behavioral intervention should be tried first before medication. Only in the case of severe symptoms should medication be introduced at the outset of the treatment. Because
what would you call severe then? Being kicked out of school 2 times, or what?
Where they just their emotional regulation is really off the wall. They're overreacting to things. They are highly impulsive. Aren't getting any of their schoolwork done. Are disruptive at home, disruptive at school. The questionnaires, of course, come up with ratings so that you would see the severity of the symptoms, and like the CPT test, the continuous performance test that I was talking about. Those kids with high scores on that would be the ones where you would say, I think we really need to get your kids on meds. That will kind of settle things down so that they will respond to the behavioral interventions.
I know you're probably hesitant to answer the question I'm about to ask you just because it's complex and it may put you on the spot, but there's got to be in 25 years certain meds that you think are more effective than others, aren't there?
Yes. Actually, where the science is going is really exciting in medications for psychiatric disorders in general, is that now that we've cracked the genome, every research study practically that's being done with meds has a genetic component. We will get to the point where we will be able, through genetics, to tell you what type of ADHD or depression you have. We'll be able to then say, based on that, these are the meds that should work best, and based on another factor, this one probably is going to cause some severe side effects, so we'll take that out of the mix. That's where we're going that's where research is going in psychiatry, and it's very exciting. So we will get to that point. But again, even with, I mentioned depression, even with depression, the new research is kind of saying that if you have mild to moderate depression, cognitive behavioral therapy is probably the right intervention for you. So I think that a majority of cases could be treated effectively initially with the right psychological intervention, and those with severe symptoms or are not responding well to the psychological interventions would be the candidates to take the medications.
And with that, what are the medications that you have high esteem for at this juncture?
Well, I think there are, the stimulant medications have been around for a long time, and those are really the tried and true medications. I mean, there's still quite a few kids on Ritalin, but the ones that there's like Adderall, Concerta, are two that are probably widely prescribed, that have really good long-acting mechanisms. Each of those is a sort of a different class of drugs, so some will work better on one individual than another. See, this is where the problem lies, is that you may take one stimulant and it doesn't do anything for you or causes some side effects, and if we switch to another stimulant but in a different type of stimulant, you may do fine with it. So, there's Adderall, Concerta are quite prescribed, and there's a new one out also called Vyvanse, which is another stimulant medication that has a very sophisticated time-release mechanism that seems to carry kids throughout the day, and for the most part, the side effects are minimal. Most of the time, the side effects that a child may initially have are a decrease in appetite and difficulty sleeping, which they tend to get past, or you can kind of modify their lifestyle in a way to get around those.
So these medications would speed them up. Is it because it's producing more dopamine? What does it actually do?
Yes, actually,